Hello there, are you okay? Thanks for joining me. My name is Dr. Rajiv. This is my education channel, YouTube Surgery and Orthopedic Education. In this lesson, I shall cover 10 important MCQs on the topic Basic Surgical Anatomy and Physiology for the preparation of INI-CET, NEET PG, INI-SS, FMGE and UPSC Combined Medical Services examinations. Each MCQ will be followed by a detailed description. You may prepare a note of important points for future reference. A lot of important stuff will be delivered in this talk, so hang on till the end. Thank you. The correct answer in question number 1 is option B. The popliteus muscle arises from the lateral surface of the lateral condyle of femur as well as from the lateral margin of the lateral meniscus of the knee joint. Some fibers also originate from the fibular head. Its origin is intracapsular. It inserts on the posterior surface of the shaft of tibia above the soleal line. Its nerve supply is through the tibial nerve. It unlocks the knee joint by causing lateral rotation of femur on tibia. The thyroid gland is entirely covered by two capsules. Just outside the gland is the true capsule. True capsule is actually a peripheral thickening of the glandular tissue. It forms septa into the gland parenchyma, dividing the gland into lobules. There is a dense capillary plexus deep to the true capsule. This is why, to minimize hemorrhage during thyroidectomy, the gland is removed along with the true capsule. This architecture can be compared with the prostate, where a venous plexus lies between the two capsules of the gland, and during prostatectomy, both capsules are left behind to avoid excessive hemorrhage. Outside the true capsule, there is a false capsule. It is derived from the pretracheal fascia, which is a layer of the deep cervical fascia. The pretracheal fascia is attached above to the body of the hyoid bone as well as to the oblique line of the thyroid cartilage. After enclosing the thyroid gland, it descends down in front of the trachea and fuses with the pericardium. On the medial side of the thyroid lobes, it forms a ligament known as suspensory ligament of Berry that connects the thyroid lobe to the cricoid cartilage. You can recall that the deep cervical fascia encloses the neck viscera, including the thyroid gland, larynx, and trachea. In Hashimoto's thyroiditis, the pretracheal fascia becomes very thick. This leads to difficulty in identification of recurrent laryngeal nerve and parathyroid glands during operations. Hence, meticulous dissection and the use of bipolar diathermy are needed close to the thyroid capsule to prevent the injury to the perithyroid structures. Though the false capsule is very thin, it forms the first barrier against extrathyroidal extension of thyroid malignancy. The correct answer in question number 3 is option B. Superior orbital fissure is a part of orbital apex. This fissure separates the greater and lesser wings of the sphenoid and lies between the optic foramen and the foramen rotundum. The nerves passing through the superior orbital fissure are Lacrimal nerve, a branch of ophthalmic division of trigeminal nerve. Supraorbital or frontal nerve, also a branch of ophthalmic division of trigeminal nerve. Nasociliary nerve, also a branch of ophthalmic division of trigeminal nerve. Trochlear nerve, superior division of the oculomotor nerve, inferior division of the oculomotor nerve, and abducens nerve. The difficulty in focusing or loss of accommodation and double vision or diplopia in this patient was due to compression of oculomotor nerve. The loss of corneal reflex was due to compression of nasociliary branch of the first division of the trigeminal nerve. Infiltrative compression of structures passing through the superior orbital fissure due to metastasis from lymphoma caused such multiple cranial nerve lesions seen in this patient. But more common causes of such lesions are traumatic and inflammatory. Now we come to other options. The inferior orbital fissure lies in the floor of the orbit inferior to the superior orbital fissure. The nerves passing through this are infraorbital nerve and zygomatic nerve. The optic canal transmits optic nerve. The foramen ovale transmits the mandibular nerve and the lesser superficial petrosal nerve. The foramen rotundum gives passage to the maxillary nerve. Structures passing through the foramen lacerum include greater petrosal nerve and deep petrosal nerve. The correct answer in question number 4 is option B. The vermiform appendix is supplied by the appendicular artery. It is a branch of the lower division of the ileocolic artery. It passes behind the terminal ileum and enters the mesoappendix. Sometimes an accessory appendicular artery may be present. The accessory appendicular artery is a branch of posterior cecal artery which arises from ileocolic artery. The appendicular artery is an end artery. Its thrombosis results in gangrenous appendicitis. The ileocolic artery arises from the right side of the superior mesenteric artery. The ileocolic artery supplies blood to the terminal ileum, ileocecal valve, cecum, vermiform appendix, and the proximal ascending colon. The correct answer in question number 5 is option D. The short gastric arteries are 5 to 7 small branches of the splenic artery. These arise near the termination of the splenic artery. The short gastric arteries are also known as vasa brevia. These supply the fundus of the stomach along its greater curvature from left to right. The short gastric arteries run between the layers of the gastrosplenic ligament. The correct answer in question number 6 is option B. The ligament of Treece suspends and supports the duodenojejunal flexor. Distal to this ligament, the jejunum starts. Anatomy and location of the ligament of Treece helps clinicians, surgeons, and radiologists a lot. It is also known as the suspensory ligament of the duodenum. Ligament of Treece arises from the right crus of diaphragm on the right side of esophageal hiatus, passes downwards behind the pancreas and extends to the duodenojejunal junction. It is attached to the posterior surface of the duodenojejunal flexor and the third and fourth parts of the duodenum. From above downwards, it is made up of striated muscle fibers, elastic fibers, and smooth muscle fibers. In normal conditions, its function is to increase the angle of the duodenojejunal flexor. It stabilizes the duodenojejunal flexor and prevents it from being displaced. It is a surgical landmark for identifying the duodenojejunal flexor and marks the point of transition from foregut to the midgut. It helps classify the location of gastrointestinal tract bleeding. When bleeding occurs above or proximal to the level of this ligament, the bleeding is called upper gastrointestinal bleeding. And if bleeding occurs below or distal to this, then it is called lower gastrointestinal bleeding. The ligament of Treves plays a fundamental role during embryonic development of the gut. It holds the duodenum during rotation of the gut around the superior mesenteric artery. Any abnormal increase in the length of the ligament can cause intestinal malrotation, whereas abnormal thickening, hypertrophy, or shortening of the ligament can lead to superior mesenteric artery syndrome. Now we come to the option A, that is the ligamentum teres. There are two this named ligaments. One is related to liver and another to hip joint. First is the ligamentum teres of hip. It is also known as the ligamentum femoris capitis. It is an intra-articular, extrasynovial ligament of the hip. The second is ligamentum teres hepatis. It is also known as the round ligament of the liver. It is a fibrous cord formed by the obliterated fetal umbilical vein. It runs in the free edge of the falciform ligament from the umbilicus into the left lobe of the liver. The falciform ligament of option C is a sickle-sepal fold of peritoneum that attaches the liver to the anterior abdominal wall. Falciform ligament divides the liver into left and right lobes. The hepatoduodenal ligament of option D is the thickened free right margin of the lesser omentum. It connects the porta hepatis of the liver to the upper border of the first part of the duodenum. Structures of the portal triad, namely hepatic artery proper, common bile duct and portal vein, run through its free edge to reach the liver. The correct answer in question number 7 is option D. The pouch of Douglas is also known as the rectouterine pouch because it is a potential space between rectum and uterus. The anatomist James Douglas described this anatomic space. It is found by the reflection of the peritoneum between the posterior wall of the uterus and the rectum in females. It is the deepest and most dependent point of the peritoneal cavity in anatomical position. It is a common site for the spread of pathologies such as fluids, tumors and endometriosis. Fluid or pus can accumulate here and a procedure named kuldosynthesis is performed to get samples for diagnosis. Kuldosynthesis is a diagnostic procedure that involves inserting a needle into the pouch of Douglas to remove and test any abnormal fluid collection. The correct answer in question number 8 is option A. Gastric juice is a mixture of mucus, hydrochloric acid, pepsin, intrinsic factor, gastric lipase and gastric amylase. Hydrochloric acid is secreted by parietal cells which are also known as oxyntic cells. The function of HCl is to convert pepsinogen secreted by chief cells into pepsin and to kill pathogens present in food. The parietal cells are present in the body of the stomach. Therefore, the body is the acid-secreting part of the stomach. Parietal cells also secrete the intrinsic factor, which is essential for vitamin B12 absorption. Hence, is crucial for a healthy nervous system and blood cell production. This is why, in autoimmune gastritis, there is atrophy of the parietal cell mass leading to hypochlorhydria, achlorhydria and malabsorption of vitamin B12 which if untreated may result in pernicious anemia. Hydrogen ions are produced by the parietal cells by active proton pump against a big concentration gradient. Many factors stimulate the parietal cells. The most important of these is histamine. Histamine acts via the H2 receptors. Blocking H2 receptors reduces acid production drastically, hence H2 blockers like ranitidine are useful therapeutically. The chief cells in option B secrete gastric lipase, which breaks down short and medium chain fatty acids. Remember, G cells of option C are not goblet cells. G cells are gastrin producing cells located in the pylorus region of the stomach. The goblet cells of option D are mucus secreting epithelial cells. The explanation of question number 9 is a bit complex. Efferent peripheral nerve fibers conveying pain and temperature and touch sense from the limbs and trunk pass through the dorsal roots and enter the dorsal horn of the spinal cord. Here they cross and ascend in the opposite anterior and lateral columns of the spinal cord and through the lateral side of medulla of brainstem to the thalamus and ultimately terminate in the post-central gyrus of the parietal cortex. This pathway is called a spinothalamic tract or enterolateral system. On the other hand, pain, temperature, vibration, fine and crude touch, and proprioception from the face and head are conveyed through the spinal trigeminal system. The spinal trigeminal nucleus is located ipsilateral in the lateral medulla and can be affected in occlusion of the posterior inferior cerebellar artery. In the patient in question, the ipsilateral loss of facial sensation is due to a lack of blood supply via the posterior inferior cerebellar artery to the spinal trigeminal nucleus. Atherothrombotic occlusion of the vertebral artery or posterior inferior cerebellar artery or medullary artery causes ischemia of the lateral medulla. This results in a syndrome of numbness of the face on the same side of the spinal trigeminal tract involvement and contralateral limbs, as well as ipsilateral diplopia, hoarseness, dysarthria, dysphagia, and Horner syndrome, known as lateral medullary or Wallenberg syndrome. Thus, the lateral medullary syndrome affects the spinothalamic tract as a spinothalamic tract runs in the lateral aspect of the medulla, resulting in loss of pain and temperature sensations over the entire contralateral side of the body as well as on the ipsilateral face due to the spinal trigeminal tract involvement. The lateral medullary syndrome causes dysphagia and hoarseness due to lesions of the nucleus M.B.B.S on the same side. Therefore, from the above discussion, now it should be clear in the viewer's mind that the given patient's whole clinical condition can be explained by a lesion of the posterior inferior cerebellar artery, which in an elderly patient of 80 most commonly results from an atherothrombotic stroke. It must be remembered that the posterior inferior cerebellar artery originates from the fourth segment of the vertebral artery at the lower border of Pons. The most appropriate answer in question number 10 is option C. The facial nerve, retromandibular vein and the external carotid artery, either in part or in whole, pass through the parotid gland and branch within it. The facial nerve is the most superficial structure. 80% of the parotid gland lies superficial and 20% deep to the nerve. Inside the gland, the facial nerve trunk divides into its 5 terminal branches. These radiate like a goose foot and come out through the anterior border of the parotid gland and supply the muscles of facial expression. This branching pattern of the facial nerve is termed pes anserinus. The consideration of the course of the facial nerve is essential for parotidectomy classification. Parotid tumor excision techniques are classified on the basis of the plane and the existence of the facial nerve. The parotidectomy is called conservative when the nerve is left in its place, and it is radical when the nerve is removed en bloc with the tumor. It is called superficial when the part of the gland superficial to the facial nerve is removed. In deep lobe parotidectomy, the part of the gland underneath the facial nerve is removed. And in total parotidectomy, the whole gland is removed together with the facial nerve. Now we shall talk briefly about other options. The retromandibular vein is formed by the union of the superficial temporal vein and maxillary vein. It occupies the intermediate zone of the gland. The external carotid artery occupies the deep zone of the gland, and within the gland it divides into superficial temporal and maxillary arteries.